Next is about the moodhagarbha. अथा तो moodhagarbhanidanam व्याख्यास्यामः यथोवाच भगवान् धन्वन्तरिः. A moodhagarbha means a fetus which has failed to progress during the labor. Mudhe niruddhagatihi. Mudha niruddhagatihi. That's where the gati or the movement has become obstructed. तदुक्तं सर्वावयव सम्पूर्णः मनोबुद्ध्यादिसंयुतः विगुण अपार सम्मूढः मूढगर्भो अभिधीयते. When the fetus has fully developed and it has reached the level of perperium but is not progressing, then it's called as moodhagarbha. It's not that the failure of pregnancy or failed pregnancy in the earlier stage is not considered as moodhagarbha. Only when the fetus has fully developed and then it results in the failure of the progression of labor, that's considered as a moodhagarbha. So that has to be very clearly understood. Gramya dharma, yana, vahana, ardhogamana, praskarana, prapatana, prapidana, dhavana, abhigata, vishama, shayanasana, upavasa, vegabhigata, ativuksha, katutikta, bhojana, शोक अतिसार सेवन अतिसार वमन विरेचन प्रेंखन प्रेंखोलन अजीर्ण गर्भशातन प्रभृतिभिः विशेषैः बन्धनात् मुच्यते गर्भः. फलमिव वृन्दबन्धनात् अभिघातविशेषैः स विमुक्तबन्धनः गर्भाशयम् अतिक्रम्य यकृत्प्लीह अन्त्रविवरैः अवस्त्रं समानः कोष्ठसंक्षोभम् आपादयति. तस्याः जठरसंक्षोभात् वायुः अपानो मूढः पार्श्वबस्ति शीर्ष उदर योनिशूल आनाः मूत्रसङ्गानाम् अन्यतमम् आपाद्य गर्भं चावति. तरुणं शोणितस्रावेण. Now, a failure of pregnancy can occur due to either the physical activities of the mother, like Gramya Dharma, that's the sexual indulgence, or Yana Vahana, traveling on vehicles, Arthogamana, walking, or falling, or sleeping on the floor, or compression, or running, etc. There are different varieties of the trauma, or it could be like fasting, or it could be due to suppression of the vegas, the urges of work, its natural excretions, or it could be due to the food, katutikta bhojana, shok, etc., or emotional disturbance like the strong emotions like distress or so on, or it could be like induced due to the woman or the village vomiting or maybe the diarrhea like conditions, or it could be rigorous movements of the body like prencholana. Prencholana is this hammock over the hammock just flowing across like. Then ajirna garbha etc. Now garbhashatana prakriti, if there is a induced induction of the labor, in such conditions the fetus which has become embedded may get detached, and it's detached like the comparison is like a fruit getting detached out of its petiole. Now, when it has become detached before the completion of the pregnancy, before the completion of the growth, then it may just get displaced and then produce a distress in the abdomen and affect the internal organs of the abdomen. Internal organs of the abdomen like yakut, pliha, antravibara, etc. So it can perforate or reach to the abdominal cavities also, and it can produce the distress in the abdomen, and due to that distress of the abdomen there could be apanavata vikriti, and this can result in garbhachavana. Now tarunam shonitasravena, if it is in the initial stage of this conception up to about 3 months, is called as shonitasrava. तमेव कदाचित् विवृद्धम् असम्यगागतम् अपत्यपतम् अनुप्राप्तुम् अनिलस्य मानं विगुणापानसम्मोहितं गर्भं मूढगर्भम् इत्याचक्षते. When it has become mature and at the time of the perperium it's not properly moving in the proper direction or the proper presentation. The presentation and the exit positions of the fetus are not normal, and hence it has become blocked. That's considered as a Mudhagarbha. So Shonita Srava or Garbha Srava is one, and Mudhagarbha is the other. Shonita Srava or Garbhapata or Garbha Srava are for the term when a non-viable fetus has become expelled out. A viable fetus, when it has failed to get expelled out, that's considered as a Mudhagarbha, that obstructed labor as such. Now, from the current point of view, whenever you look at the issue of a pregnancy loss. Now, we use the term pregnancy loss and then the malposition and malpresentation or failure of perperium. That pregnancy loss or garbhapata, as Sushruta has mentioned, now can be categorized as a threatened, inevitable, incomplete, missed, or septic, or complete. These are causes as the types of the garbhapata or pregnancy loss, or what we call as the abortions. Now, that abortions could be threatened where it is presented as a vaginal, we define these as a, and there is a vaginal bleeding, but os is closed after the conception and usually within 6 months of the pregnancy. Usual terms are for the 6 months of the pregnancy or where the fetus is still not viable. A non-viable fetus presenting with the vaginal bleeding and os is closed, then it's called as threatened abortion. When there is a bleeding and the os is partially dilated, patient is presenting with the pelvic pain, it's called as inevitable. So the difference is in a threatened abortion, you may still try to save the fetus. Inevitable and incomplete conditions, it may not be possible to save the fetus. So all that would be to minimize the complications. Approach would be minimize the complications. And that's why these definitions are important. Inevitable is when the os is partially dilated and there is a pelvic pain. Incomplete is products of conception have been partially expelled out and os is dilated. Patient has cramps. Missed is bleeding and os is close to fetal death has occurred. There are no signs of viable fetus then. Then our septic is evidence of infection. Complete is where there is a complete expression. This is how it's classified. And as far as the causes for the pregnancy loss are concerned, the usual causes are genetic or anatomic abnormalities of the fetus or the mother, then autoimmune conditions like clotting disorders, infections, and then endocrine hormonal pathology. Abnormalities of endocrine hormones that considers is 15 to 20%, and more than 40 to 50% of the abortions, the real causes are not known, unexplained. So that's all. We only in about 40, 50 to 60% of the conditions, the real cause can be made out, and around 50% of the conditions for the abortions, the real causes cannot be made out even with the advanced technology and advanced assets. Now, we, for the sake of the real progression of the labor or the normal labor, to understand Mudagarbha, the labor process is categorized into three stages. This is how we study the obstetrics as such, and that it's a first stage, second stage, and third stage. The first stage is begins with the regular uterine contractions and ends with a complete os dilatation of about 10 centimeters. And again, it could be categorized into two phases, latent and active phase. I think these are all the subjects of obstetrics, but still you have to have some idea to understand the concepts of Mudagarbha. The latent phase is where the patient will have mild uterine contractions and it makes the cervix soft, and the contractions gradually become increasing. The cervix may not be fully dilated. The active phase begins once the cervix has become dilated by around 3 to 4 centimeters, or what we call as a two-finger dilatation, and characterized by rapid. Then further, once it reaches that level, the further dilatation becomes rapid, and you'll also have sign of the descent of the presenting part. Second stage is when there is a complete dilatation started, a complete dilatation has occurred, and it usually ends in the delivery of the fetus. And usually, again, we say that in an nulliparous woman, the second stage should be considered as a prolonged. It's around up to it should be within 3 hours. If it is exceeds 3 hours, then it's considered as prolonged. And if regional anesthesia is administered, then 2 hours as such should be the, sorry, 3 hours if regional anesthesia has has been given. 2 hours without that anesthesia, it should end up with that. If the second stage doesn't end within 2 hours or 3 hours as per the criteria, then it can be considered as failure of progression or a labor progression error. It could be one variety of the Mudagarbha. The causes could be many. Causes could be either it could be, we'll come to that part, uterine or maybe the fetal causes. And in a multiparous woman, the second stage should be considered prolonged if it exceeds 2 hours with the regional anesthesia and 1 hour without it. In third stage is where the placenta is expelled out and it should be completed usually within 30 minutes. If it is beyond 30 minutes, then it's considered as a prolonged. So when we discuss Mudagarbha, it's about the second stage, which is the most important. First and second stages, of course, are the most important things which we consider about the Mudagarbha. Third stage, of course, from the Mudagarbha point of view, has a lesser significance, but from the clinical obstetrics point of view, it should be seen, and usually the third stage would not be beyond 30 minutes as such. Now, the mechanism of the labor, that is, it's again, I will not go into the details of obstetrics, but you need to understand that principles, and that's why I'm just referring to that. The labor, during the process of the labor, the changes in the position of the fetus is again, it should follow a proper method. The first of the thing is the engagement, where the presenting part would be directed towards the cervix, and the usual normal, which we call as normal presentation, is the occipital presentation. The head would be presented either it's occipital anterior or occipital posterior. The head either anterior or towards the posterior. Occipital anterior is most common, and it could be again left or the right. So usually it's a left again. Left occipital anterior is the usual most convenient position. So when the head is reaching up to the pelvic girdle and has reached the end of the fundus of the uterus and has become fixed, like, then we consider it as become engaged, where it cannot be moved. Then when it has descended down beyond that symphysis pubis, then it's a descent as such. Now, once it has descended, it's usually in the beginning of the second stage. The descent starts with the beginning of the second stage of the labor, and further during for the proper expulsion of the fetus through the narrow opening of the vagina, it need to have a normal procedures or normal steps of the these mechanism as such, normal steps of the mechanism. Otherwise, if these steps are not followed or somehow something goes wrong, then again it can be a cause for the failed labor or obstructed labor. Now, what happens is the presenting part initially gets flexed. It should get flexed to follow that path of the passage, the uterine passage, and then vaginal passage. Then, once that flexed presenting part is delivered, that head has become delivered, then the whole body should get internally rotated. The one side, either the left or the right, would be presenting further, and that's what you call as the internal rotation. So either it should be the left arm and left shoulder, or the right shoulder, which would be coming through. Then the extension, the next part is the head should be extended. Now this is the real position where the obstetrician should help. Like now, a person who is attending the delivery, it could be obstetrician or nurse, whoever it is, should extend the presenting part, and this extension of the presenting part would be one of the critical issue to help the labor. Of course, even without a help also it can occur, but to facilitate the labor, an extension from the exterior is necessary. Once it is extended out, this presenting part is extended, the shoulder, which is the widest portion of the body, widest part of the body, can easily get delivered, both the shoulders. Once that, see, in the internal rotation, initially it will be one shoulder, maybe left or right, would be pushed down, and once it is extended, then both the shoulders can easily get delivered out. And then you may have an external rotation, turn the baby towards the anterior side, and then the whole expansion occurs. So, for a normal labor, attending the normal labor, and you need to have this kind of idea of these 7 steps of the labor, and that should be facilitated. A normal labor facilitation would be facilitating these 7 these steps as such. Now, the normal presentation, we usually consider this as, there is actually, to use the word normal is not very correct. Instead, it's the common, most common and easy to deliver positions are either it should be the posterior anterior, this occipital posterior, or it could be occipital anterior. Occipital anterior is considered as abnormal, and occipital posterior, posterior occipital area is the normal position. The head would be face would be backward as a occipital anterior. Occipital anterior is the normal position, occipital posterior is the abnormal position, where the occipital bone would be towards the anterior side. Correction. So I think I have told the other way. Occipital anterior is the normal position, occipital posterior is the relatively abnormal position, where the flexion and extension would not be possible. And these steps, of course, why these steps are important, flexion and extension, is to facilitate the presenting part to get expelled out easily through a narrower opening. So actually the width of the shoulder is almost the same as that of the cervix, or maybe wider than the cervix. Cervix being flexible, it should be expelled out, and hence these flexion and extension of the neck are very critical issue. Flexion and extension of the presenting part would be a critical issue in the normal labor. This is how it is done. And the shape of the fetus is another issue. That presenting part, if it is altered, and instead of the normal progression, if a wider part is expelled out, or if there is something which can change this shape of the whole area. Now, in the normal labor, to facilitate the normal labor, there should be a diagrammatic representation of the body, like the pointed portion should be expelled out first and the wider portion would be the next. If this occurs, if this changes, and there is an abnormality of this or disparity of the circumference of the body and circumference of the passage out, then there could be an abnormality. Now, abnormal labor, to consider whether it's an abnormal labor or not, we have certain criteria. And that criteria in the obstetric practice, regular obstetric practice, are either a prolonged latent phase. Now, this criteria is quite important to say that whether there is a need for intervention or not, or intervention like LSTS and so on. And these criteria are quite critical, important from the clinical point of view, and have a judicial value later on if there is any litigation issue, like whether the LSTS is necessary or not, to substantiate that that intervention was necessary, or if anything goes wrong, if there is any legal issue. These recording of these are quite important in cases of the handling of obstetric conditions. Now, if the latent phase of the pregnancy, that's the first stage, is more than 20 hours in nullipara, whereas 14 hours, more than 14 hours in MIT, and the second stage, if it has gone beyond 50 minutes in a nullipara or 20 minutes in a multipara, our second stage, prolonged, it's a with or without epidural, the same issue which we have discussed already, 2 hours or 3 hours. Then dilatation, if it has become slower, a slower dilatation, like if it is less than 1.2 centimeter per hour in early and multipara 1.5 centimeter per hour, if the descent is delayed or protracted, slower, like if it is less than 1 centimeter per hour in an nullipara and less than 2 centimeter in an hour in a multipara, and if the dilatation has become arrested, if it doesn't go beyond or doesn't increase for 2 hours, dilatation has stopped and it's not occurring for more than 2 hours, or if there is a descent has become arrested, doesn't arrest even after 2 hours of observation, or if the third stage is prolonged. Now, that's a relatively less important condition. These are the real reasons for the intervention. And the causes could be, the most common causes would be fetal malpresentation, malposition are the most common causes. And when Sushil has discussed about the Mudhagarbha, the Mudhagarbha mainly, almost all Mudhagarbha is limited to the fetal malpresentation and the malposition. The other issues like fetal weight, pelvic abnormalities, uterine contractility or inertia, and maternal health conditions, these are not included in the context of Mudhagarbha directly, though they are understood. So we need to have a clear idea of what is to be discussed in the Mudhagarbha. Mudhagarbha doesn't discuss about the whole obstetric practice. Is only one component of the obstetric practice where there is a need for intervention, and that intervention is mainly for the fetal malpresentations and the malpositions. And the force of the labor ideally would be like initially the uterine tone would be increased up to the first stage, and in the second stage there will be a rapid increase in the uterine tone, and then gradually it should be relaxed. That's how it should be maintained. Now, with this background information to understand, we directly go into the Moodhagarbha types and then their details. Tatra Kilaha, Pratikuraha, Bijagaha, Parigaha, iti. The Moodhagarbha, they are mainly of four types, and then again there are four subtypes, and hence it becomes totally eight. Now, Tatra Urdhava Shirapadaha Yo, Yonimukham Nirunadi Kila Iva Sakilaha. If the presenting part is not the limbs or the head, instead, if it is a buttock and the limbs and the head is towards the proximal side, superior side, then that condition is called as the Kila. Now, Kila, now we identify this as the breech presentation. So, instead of the head being presenting the part, if it is a breech which is a presenting part and all the limbs are folded and superior, that's what we call as a frank breech. Again, in frank breech presentation, you have subtypes, and a frank breech is obviously the Kila. Mr. The Hasavadishira Kaya Sandhi Pratikhura. Pratikhura is where one arm has become presented out, whereas the head and the neck has become obstructed. Now this is a very critical issue from the practical clinical point of view. A shoulder or a limb presentation is a very critical condition where if we do not intervene immediately, there could be serious complications, and the it's comparatively rare. Incidence is comparatively rare. But if at all this occurs, if one arm has become expelled out, and the head is not really coming to the presenting part, is not getting even engaged. Many times it may fail to get engaged, and there is no question of descent. Such a condition is called as a pratikura, a limb presentation, which is very critical and very difficult to handle. Very difficult to handle conditions as such. Then Sanirgatyat Ekashiro Bijaka. Now in the limb presentation again, there could be a situation where the head also is presented along with the limb. It's a partial limb presentation, and this can be somehow managed. Now this can be somehow managed if you take care of the other limb. Difficult, but can be managed. Compared to that unified limb presentation with the head not being present in part, this kind of limb is usually is somewhat better than the earlier one, and this is what Sushra has considered as bijagaha. So nirgachati ekashiro bhujaha. One arm and the shira head has become presenting part. यस्तु परिगः वै योनिमुखम् आवृत्य तिष्ठति स परिगः इति चतुर्विधो भवति इत्येके भाष्यन्ते. Now, according to some, there are four varieties, and the fourth variety is a parigha. Parigha is where the whole body has become transversely presented and it blocks the passage. The whole body is blocking the. It could be either a transverse presentation with the back as such, breech as such, or it could be very rarely a transverse presentation in the face or retrover transverse presentation. Comparatively, this is rare, whereas most frequent transverse presentations are these. From the practical clinical point of view, if the transverse presentation is identified early, then it can be somewhat managed by an external rotation. External manipulation is often possible, so it can be tried. So intervention, direct intervention can be avoided if you have a skill of handling these transverse presentation. Now, anyway, that's about the four types. Now, during Sushruta doesn't accept that four types. He says there could be many multiple varieties of the malpresentations. Those are Tattuna Samyaka, Kasmata, Sayada, Viguna Anila Prapirita, Apakyapatam, Anekada Prapatyate, Tata Sankhya Hiyate. That number of four types is not a critical issue. It can be any number, innumerable forms of the presentation could occur. And that's what I said. In the case of transverse presentation, the manipulation is one of the techniques used, and in a skilled hand, successful manipulations are done quite frequently, and the transverse presentation BB can be manipulated as such. Then those other varieties which are mentioned by Sushila are तत्र कश्चित् द्वाभ्यां शक्तिभ्यां योनिमुख्यं प्रतिपद्यते. This is a rare presentation. Of course, from the practical clinical point of view, incidence of a double foot limb presentation is rare, where both the lower limbs are presented or at times upper limb. Now, this also is a difficult condition because there is always a possibility of asphyxia in such a condition, and delivery needs a lot of skill there. But still, a vaginal delivery may be possible. LSCS can be avoided in such conditions, but It's rare, not a frequent one. Kashchid dvabhyam saktibhyam yanimkam pratipadyate, where both the limbs. Now, of course, from the clinical point of view, either it could be a single footling or double footling. Double footling is what Sushil has mentioned as a one of the varieties for that, whereas in the present day situation, you may have both these presentations. Now, then Kashchid abhugna ekasakti ekena. Now, ekasakti, one partial footling presentation also is another of the variety mentioned by Sushila. So that footling either double or single are the two other varieties. Then कश्चित् आभुग्न शक्तिः शरीरः स्विग्देशनतिर्यगागतः. Now again a breech presentation where instead of a total or complete breech or full breech, it could be a partial breech where either the sacrum, left sacrum being anterior or the left sacrum being posterior, and slightly twisted, abhugna sakti sharira, a bent body, but it's the speak or the breech which is presented. This again is a difficult issue, particularly difficult because you cannot feel the parts of the pregnant, these late fetus easily, and you will always be confused about that. So clinical handling or identification of this presentation could be quite difficult. Then कश्चित् दूरपार्श्वपृष्ठानाम् अन्यतमेन योनिद्वारं पिधाय अवतिष्ठते. A incomplete breech presentation where instead of the breech it is the back which is presented, neither transverse nor a breech. So in between, transverse where the whole body would be kept transverse, whereas in a partial breech, these are also called as incomplete breech presentations, where it's not the breech, but it could be somewhere either the shoulder or the back which can get flexion. This again is quite difficult, where the progression of the labor is virtually not possible. So that's about the other variety of the presentation. Then Antaparsha Apavritta Shiraha Kashti Dekena Bahana. Now again a single limb presentation with the head extended. Now, this again is very critical, and from the clinical point of view, incidence is very rare, but it's very critical. And most of the times, if at all such a position has occurred, the result would be almost fatal because that extended head cannot be easily delivered, and limb has become presented. So, chances of asphyxia are quite high, and uh, most of the times it can result in very critical, serious issues. Comparatively, incidence is less common. So that's another of the presentation which can occur. Then Kashchid Abhugna Sharira Bahutver is again extremely rare position where the presenting part would be the head and limb, but both the limbs being extended. See, normally a fetus position would be limbs would be flexed but, in the uterus. But if the limb becomes extended, that's another of the condition, which is not regularly seen. It's a very rare situation, and very few conditions are reported, and in that's about one more of the presentations as such. As far as the clinical presentations and recording are concerned, documents are concerned, this kind of a presentation is almost rare. Then Kashchid Abhugna Madhyaha Hastabhada Shirobhi. Now another of the similar transverse presentation. This is a variation in the transverse presentation. In the transverse presentation, if the arms are not really flexed and they tend to be extended, that's what Sushila has said. Kashchid Abhugna Madhyaha Hastabhada Shirobhi. That's or antegrade transverse presentation where the arms would be presented, and this also can be manipulated. This also can be manipulated from the present clinical point of view. We do not make a huge difference in these two conditions. Instead, we consider these as transverse presentations and attempt to manipulate. External manipulation is the usual choice as said. Then कश्चित् एकेन सत्ना योनिं प्रपद्यते अपरेण पायुम् इति अष्टधा मूढगर्भगतिः uddishta. Now this again is a very unusual situation where one limb is presented through the vagina, the other limb may be towards the rectum and pushing the rectum where it can even perforate. Now this is again a rare situation, a foot limb presentation with an extended foot. This also is rare. Virtually such conditions are very few recorded, and there is only one, I think I could find only one recording of this issue, kind of a presentation. So, injury to the rectum also is one of the possible complications. These are the 8 types of the Mudagarbha mentioned by Sushruta. तत्र द्वावन्त्यौ असाध्यौ मूढगर्भौ ಶೇಷಾನಪಿ ವಿಪರೀತ ಇಂದ್ರಿಯಾರ್ಥ ಆಕ್ಷೇಪಕ ಯೋನಿಭ್ರಂಶ ಸಂವರಣ ಮಕ್ಕಳ ಶ್ವಾಸಕಾಸ ಭ್ರಮರಿ ಪೀಡಿತಾನ್ ಪರಿಹರೇತ. Now, the last two, the limb presentations and the presentations with the rectum possibly, are difficult to be treated or asadhya. In the other conditions also, they are difficult to be treated, and if at all, it is accompanied with the maternal issues, like if the mother has become semi-conscious or unconscious, or convulsions are there, convulsions are presented, as in case of these yeah, toxemia-like conditions. Then Yoni-Bhramsha, if there is anatomical this uh, yeah, uterine eversion of the uterus occurs, Yoni-Bhramsha, or Samvarana, if there is a premature contraction of the uterus, or Makkala, retention of the placenta. These are the complications which can again produce fatal complications, make it asadhya. Now, in the normal labor condition, कालस्य परिणामेन मुक्तं वृन्ताद् यथा फलं प्रपद्यते स्वभावेन नान्यथा पतितुं ध्रुवम् एवं कालप्रकर्षेण मुक्तो नाडीनिबन्धनात् गर्भाशयस्थो यो गर्भः जननाय प्रपद्यते. Now, what makes the normal labor, according to Sushruta, it is a kala parinam, maturity. See, that's a gradual time factor. The time factor itself is the one, and once the maturity occurs, once the fetus become matured, there is a natural cleavage and natural separation, and this natural separation is compared to the separation of a fruit from its pedicle, and that's a normal labor where there will be not much of a distress. Comparatively, it's distressless, and a normal labor can occur. And for the normal labor, it's the kala or the time which is the major important factor which it decides about, and which can be affected. This normal labor can be affected due to krimi, vata, abhighate. So the major, it could be the external contamination factors, krimi, or it could be the external trauma, abhighate, or it could be vata, the doshas in the body. In such a conditions may affect the this fetal growth as well as fetal progression. And pratati akalepi yatha tatha syat garbhavichuti, as a fruit or can get affected due to the insects or maybe the seasonal factors or maybe the trauma. Similarly, a fetus also can be affected due to these multiple factors. Now, from the clinical point of view, we generally consider that parturition or that issue of separation. Now, Shusha has considered the kala. From the present day's point of view, we consider that the initiation of the parturition as a hormonal activity. It's also named as a cascade, parturition cascade. When now, all that the difference would be, according to Sushruta, the whole process starts according to the time. Now we now identify whether the time has started or not by assessing the hormones. And these hormones are mainly regulated by the pituitary, adrenocortical, and of course the liver, fetal liver. Fetal liver also is another of the factor which decides like when the progression has to start. And the impact will be over the mothers, particularly is the mother. The posterior pituitary oxytocin is released by the posterior pituitary, which results in the contractions of the fetus. At the same time, the placenta also gets separated by the CRH hormone, the same posterior pituitary hormone, and the fetal metabolism of the estrogens also is another triggering factor. So all these are considered as a parturition cascade or hormonal changes which regulate. Now, this is a usual thing, and by assessing these hormones, now you can predict whether the progression of labor can be normal or not. आचतुर्थात् ततो मासात् प्रसवेत् गर्भविच्युतिः ततः स्थिरशरीरस्य पाकः पञ्चमषष्ठयोः. When it comes to question of nomenclature, initially when Sushra has mentioned simply rakta sruti, bleeding, now there are some specific names according to the stage of the perquirium where there is a loss of pregnancy. Now a loss of pregnancy up to the month of fourth month of conception is called as garbhavichuti. Then Sthirasharirasya Pataha, when the body has become mature and if it has occurred after the fourth month, before the full term delivery, then it's called as Garbhapata. So Garbhachuti and Garbhapata, according to Sushruta, have a very specific technical meaning. Whereas in other texts, these technical differences are not maintained, and often Garbhachuti and Garbhapata are used as synonyms. Now, in the present day situation, again, we have a similar issue of terminologies, and the terminologies which are used now are early pregnancy loss, where the pregnancy has been lost within 10 weeks of gestation, and or before at least 8th developmental week. Then a non-visualized pregnancy loss is a spontaneous pregnancy demise or loss where it's identified only with the hormonal changes and with the ultrasound. You do not have a clinical sign of pregnancy. That's called as non-visualized pregnancy loss. These are the two early stages of pregnancy loss from the current age point of view. Then miscarriage is another term used when intrauterine pregnancy has been confirmed by ultrasound or histology, but it's not really seen now. Patient might not have identified. It could be considered as a menstrual flow or abnormal menstrual flow, but pregnancy demise has been confirmed by histology or ultrasound. Then fetal miscarriage is when it's more than 10 weeks and the size of the fetus is less than 33 millimeters, which is identified with ultrasound. The word abortion is when it's before 20 weeks of gestation. This is how the terminology used now. Whereas Sushra has used only two simple terms, Garbhachuti and Garbhapata. Whereas now you have a bit more complex issues where it all depends upon whether the investigations are done with ultrasound or not. Then प्रविध्यति शिरो यो यातु शीतांगी निरपत्रपा निरोधत सिरा हन्ति सा गर्भं सचतां तथा. The signs of fetal distress. Now, we have standard clinical tests of signs of the fetal distress. Now, Sushruta mentions about that signs of fetal distress by looking at the maternal signs, signs of the mother, that fetal examination and the fetal distress assessed by this maybe a stethoscope or maybe your ultrasound or Dopplers. These are not really mentioned by Sushruta. Anyway, but when the mother's limbs become cold, signs of shock there, and she is in a very critical distress, and the vessels around the abdomen they seem to be more prominent, congestion in the pelvic area, that's signs of a fetal distress. This is what Sushruta has mentioned. Of course, now you have more objective clinical signs of the fetal distress, and diagnosis is mainly based upon the heart sounds, the rate, heart rate as such. गर्भ अस्पन्दनम् आवीनां प्रणाशः शापपाण्डुत भवति उच्छ्वासपूजित्वं शूलं च अन्तर्मृते शिशौ मानस आगन्तुभिः मातुः उपतापैः प्रपीडितः गर्भो व्यापद्यते कुक्षौ व्याधिश्च प्रपीडितः. Fetal death, signs of the fetal death, again according to Sushruta, is garbha aspandanam, where there are no movements of the fetal body, mother is not feeling the fetal movement. Avinam Prasha, no contractions. Contractions of the uterus have become lost, and there is a pallor or cyanosis of the mother, and Uchasapujito, a foul smell in the air breathed out. That's a sign of Antarmrita Shishu or a fetal death. A fetal death is says. Now, of course, you have more criteria, more objective criteria of assessing the fetal death. And the cause for this could be fetal distress or the fetal death could be manasa agantubhim matuhu patapihi. It could be psychological or physical distress of the mother which can produce the fetal distress or fetal death. Now, if at all you have identified a situation where the fetal is alive but mother has died due to some sudden injuries, भस्तमार विपन्नायाः कुक्षिः प्रस्पन्दते यदि तत्क्षणात् जन्मकाले तं पाठयित्वा उद्धरेत् कृषक. Sushruta has even mentioned the interventional procedure where the uterus can be opened and the fetus could be removed. But the only criteria is if the mother has died due to some sudden injuries. Bastamara is a guillotine-like instrument. So if at all due to sudden trauma, mother has died, but fetus is still alive. And the signs of the fetal life is seen in terms of the movement of the fetus, then it could be you have to open the abdomen of the mother and then remove the fetus. Now, of course, the caesarean section, what we call as a caesarean section, is even when the mother is alive and there is a sign of the fetal distress, and if there is a failure of the labor progress. There's a lot of difference in that perception. Anyway, that difference is to be accepted. Now we will not go more critical about that. But in Sushra's period, with the limitations, that was the indication for the abdominal, this non-vaginal delivery of a fetus, and hence concepts of the caesarean section were known to Sushruta, but the indications are different. That's all the point. With this, we end up this chapter. It is Sushruta Samhita Nidanasthane Moodhagarbha Nidanam Nama Astamodhyayah. More of these labor issues will come in the later concept parts of the Sushruta. So Moodhagarbha is about only the obstructed labor and its varieties. With this, we conclude today. If there are any questions, right? No questions. Right, then we'll conclude by end of today. Right.